Welcome back. In this part of the lecture on genital prolapse, we will discuss the surgical options. So, first, the patient needs to be carefully selected because each procedure is really may be related with some serious complications. Okay, so and it also depends whether the patient, along with vaginal prolapse, uterovaginal prolapse, they have urinary symptoms or not. Okay, because a lot of women can have associated stress incontinence or other types of incontinence. So the indications in general, they are used if conservative treatments have failed. For example, if physiotherapy didn't work or if the pessary didn't work. And then, of course, depends on patient's choice and surgeon's expertise. So choice of procedure, it also depends on the anatomical compartment affected, like whether it's anterior, posterior. If woman wants to retain, whether the woman wants to retain her uterus, because for some types of genital prolapse, hysterectomy may be the one of the choices. Then in general, see, there are some procedures which are performed vaginally and other abdominally. Vaginally means there is no cut on the abdomen. So, in general, vaginal surgeries, even if it's vaginal hysterectomy, that is safer. It is there is less complication. There is faster recovery compared to abdominal procedures. Okay, and vaginal procedures can also be performed under spinal anesthesia generally. Like vaginal hysterectomy is generally performed under spinal anesthesia. So, especially in urogyne patients, usually the patients are older and frail, and they may have medical comorbidities, and they may be unfit for general anesthesia. So, it's a benefit. Okay. So, vaginal route of surgery in general, if there is option, it's preferred. Vaginal route preferred to restore the ligamentous tissue supports to the apex, anterior and posterior vaginal repair perineal body. Okay, anyways, you just remember that vaginal route is preferable if it's indicated. Now, the one of the common types of prolapse, that's the cystocele and rectocele. But remember, not all cystoceles and rectoceles they need repair. It's only if they are causing symptoms, if they are symptomatic. Okay, and depending on the severity of the prolapse. In general, again, the patient is given spinal analgesia, anesthesia, and then basically what is done, a cut is made on the mucosa. The prolapse part is pushed back and then it is stitched. Okay, the mucosa is stitched and the redundant tissue, the extra tissue is cut. That's the general thing, but of course you don't need to go into the details. Okay, so treatment depends on presence and severity of symptoms and any related conditions such as urinary incontinence and more than one type of pelvic organ prolapse, because some women can have both, right? Some women can only have cystocele, someone can have only rectocele. So it's called anterior repair or posterior repair. Okay, in mild cases, those with few or no obvious symptoms typically don't need treatment. Okay, it's just they don't need treatment. Similarly, so posterior repair or perineorrhaphy. So perineorrhaphy means because perineum is the, so if the perineum is deficient, okay, if the perineal body is weak, it needs to be repaired. Okay, so that's perineorrhaphy. So usually posterior repair it along at the same time perineorrhaphy is also performed. Okay. Now, for uterine descent, mostly uterine descent happens in older women, but some younger women, especially depending on their profession or family history like connective tissue disorders, they may have prolapse at early age. The problem with younger women is hysterectomy may not be an option because they may need to complete their families. So there is a procedure where uterus can be retained. Okay, if the woman has completed her family, then vaginal hysterectomy, right? Especially for prostatendentia, right? And we don't need the uterus, so vaginal hysterectomy is the preferred method. Then there are some sling surgeries. Sling surgeries means using either synthetic material or even facial aorta, like even patient fascia from the patient themselves, natural slings, they are made and then the prolapsed uterus is like pulled back. Okay, it is tied to certain areas in the pelvis. So these are sling surgeries. There are different types and names of these sling surgeries which you do not need to remember. Like I remember Khanna's sling procedure, Pudendir, and so on, but you don't need to remember those that much detail. The only thing you need to remember is, so if a patient is younger and she has prolapse and we need to retain her uterus, then there is a procedure. Just remember the name. It is called Manchester repair, and it has another name which is called Fothergill surgery. Okay, Fothergill repair or Manchester repair, they're the same thing, and it means just you retain the uterus. Now, a slide about vaginal hysterectomy. So, in vaginal hysterectomy, the incision is in vagina. Okay, it's not on abdomen. Cervix and uterus are removed. Ovarian and fallopian tubes are not removed. Can be assisted laparoscopically. So there can be some help from laparoscopically. So, for example, laparoscopic removal of large subserosal fibroid and removal of uterus vaginally. Okay, that's called laparoscopic assisted vaginal hysterectomy. Okay, and then benefits. So, benefits is no abdominal incision. There is rapid recovery. It's usually performed under spinal analgesia or anesthesia. If a woman is too old, okay, sometimes because vaginal hysterectomy, compared to vaginal hysterectomy, there are less invasive. They are invasive, but like there are better procedures, less, yeah, you can say less complicated procedures. But see, after vaginal hysterectomy, women can, if she is sexually active, she can continue to have sex. But if a woman is too old, she is not even fit for vaginal hysterectomy, then there is another procedure which is called colpocolysis. Okay, so basically, what is done, the vagina is obliterated. In simple terms, it's not exactly like that, but the vagina is stitched. Okay, so it's closed in simple terms. So in medical terms, its vagina is obliterated. So that means in future, that particular woman will not be able to have sex. So we need, in history, we need to make sure, and we need to discuss it with the patient. This is this has high success rates, and but it needs to be clearly communicated to the patient. Now, remember, we said there is a condition which is called vault prolapse that happens after hysterectomy. Okay, so what is left behind was the vaginal vault, and it is coming down. Now, there are two procedures, at least remember these, which can be so. One of them is performed abdominally. That's called abdominal sacrocolpopexy, which basically means the top of the vagina. Okay, it is attached to the sacrum. And how it is attached? By using mesh, right? Like in hernia repair, the surgeons use mesh. So there are meshes. They are made of usually polypropylene. Okay, and so that's a that's a major surgery. Alternate to that is a vaginal procedure, which is called sacrospinous ligament fixation. It's again by using a mesh. Okay, so for women who are older, less fit, for them, this sacrospinous ligament fixation is the method of choice. If they are more fit, healthier, younger, then abdominal sacrocolpopexy. But this is for these treatment options are only for vaginal wall prolapse. Okay. So sacrospinous ligament fixation, it has decreased operative time, decreased incidence of adhesion formation, and quicker recovery time. And abdominal sacrocolpopexy, it can be even performed laparoscopically. Okay, it can be open or even laparoscopic. Shortened vagina or younger patients. Mainly, just remember, it's mainly for fit younger patient, and with other coexisting conditions where we have to do abdominal surgery. Okay, so if it's otherwise, abdominal is indicated otherwise. Okay. So I think we are just coming to the end of this lecture, which is the last part. So this is how like sacrospinous ligament. So this is the sacrospinous ligament, right? So it needs to be using a mesh. It needs to be kind of hooked. Okay, and same is with in abdominal sacrocolpopexy. So using a mesh, it is pulled upward so that it is not prolapsed. Okay, that's the end of this lecture. And if you have any questions, just drop